Okay, guys. This is our last one right here, and it is chapter 31. It's pain, comfort, and sleep. So pause, take a look. Pause, take a look. Pain and discomfort. So pain is the feeling of distress and discomfort. It affects or interferes with normal activity. There's no accurate objective measurement of pain, so that is important to understand. Pain assessment is performed along with each assessment of vital signs and is considered your fifth vital sign. So, pain can be experienced by most patients or is experienced by most patients. And anytime you're charting pain, you want to make sure you are charting the characteristics of pain. So, is it sharp? Is it dull? Is it burning? Is it aching? Is it squeezing? Is it deep? Is it mild? So you want to talk about intensity. Is it moderate? Is it severe? Where is the location of it? Is it on the arm? If they tell you arm, you need to know, is it in their left arm? Is it in their forearm? Is it in the side of their arm? You also want to know the onset, which means is it sudden? Is it slow? Was it a gradual buildup? How did this happen? So always take note of that. That is how you chart. This is what happens in the real world. So it's important. Surgical patients experience post-operative pain. Many medical conditions cause pain. So, headache, myocardial infarction, cancer, fractures, cuts, and abrasions. The Joint Commission pain control standards. So, patients have the right to appropriate assessment and management of pain. Pain is assessed in every single patient. Patients are educated about pain and managing pain as part of the treatment as appropriate. The discharge process provides for continuing pain care based on the patient's needs at the time of discharge. So, usually at discharge, you're always teaching the patient about their pain and what interventions you have offered for them. It could be something like exercise, stretching, strengthening, moist heat, massage, meds. There's so many different types of, ways to do that. Clarification of pain control standards. So revisions focused on including both non-pharmacologic as well as pharmacologic methods, in addition to the benefits and risks to patients when deciding the most effective pain management strategy. So I want you guys to pause and look up what are non-pharmacologic methods of pain relief, and then look up what are pharmacologic pain methods of relief. Theories of pain. Pain is defined as the feeling of distress or suffering caused by the stimulation of nerve endings. Pain serves as a warning of tissue damage and allows sufferer to withdraw from the source of the pain. Pain is transmitted through the nervous system. So, pain transmission, this is accomplished through sensory neurons to your spinal nerves and then to the brain. Once this signal is interpreted, the brain sends out a message to the body to respond. So pain receptors, they may be stimulated by this chemical feeling or thermal or electrical or mechanical agent. Severe pain can lead to shock, even death. And then the psychic reaction to pain is more subtle than reflex reactions. So as in, mentally, someone may not be able to perceive their pain as much as they would respond physically to pain. So here we have a little image of pain transmission. You can pause and take a look at it. Gate control theory. So pain viewed as being controlled by a gate mechanism in the central nervous system. Opening the gate allows transmission of pain. Closing the gate blocks the transmission of pain. The gate may be opened by activity in small diameter nerves, such as tissue damage. Then, large diameter nerve activity seems to close the gate. Lack of input allows the gate to open. So, the brainstem impulses are caused by these high sensory inputs, like being occupied with a task or being distracted by visitors or the television. And then it seems to close the gate. So, you will see pre-existing anxiety. This lowers the threshold for pain reception. It increases pain sensation and it intensifies pain reactions. There's a little image of that. Endorphins. Endorphins are endogenous, naturally occurring opiate-like peptides that modify the perception of pain. They attach to opioid receptors and block pain. Physiologic and psychological stressors can cause the release of endorphins. Long distance runners often get an endorphin high. So, the word endorphin comes from morphine, and endogenous means from within. Endorphin is a hormone, it's the brain's natural painkiller, and it stimulates this feel good feeling. Endorphins help to control pain as well as temporary pain associated with any types of exercise. There's types of pain. Pause and write these all down. You should be familiar with them. Patients' verbal description of pain and nonverbal signs of pain and the physiologic indicators of pain, they may vary depending on the type of pain that the patient is experiencing. Treatment decisions should be based on assessment that consider all of these factors. So as I said, remember this slide and write it down. Acute pain. So this is usually associated with injury, medical condition, or surgical procedure. It's a short duration. It's lasting a few hours to a few days. It may be described as aching or throbbing. Patient may be restless or agitated. It's usually controlled with analgesics. So the type of pain a patient has experienced will help determine which methods will best relieve this type of pain. Your treatment decisions are based on all of your assessments. So what was verbally described to you? What did you see? What are your nonverbal cues? You also want to think, how is acute pain different from chronic pain, which we'll talk about in a second, but start to wonder about that. You also want to think about, how does treatment differ from chronic versus acute pain. Acute pain, so some of these causes are burns, bone fractures, muscle strains, pneumonia, sickle cell crisis, angina, herpes zoster, inflammations, or infections. This may worsen in the presence of anxiety or fear. So if you are anxious or you're feeling very fearful, these pains will exacerbate a little bit more. These are usually relieved once the cause is removed. So typically in acute pain, the cause is often easily determined. You're able to know what is going on. It may also see in vital signs, you may also see that acute pain will show you increased heart rate, blood pressure, respiratory rate. Acute pain is relieved by the rest of the affected part. And medications for these infections or inflammations or whatever's going on with the patient. Pain medication can mask symptoms that the doctor needs to observe to establish a diagnosis. Relief of pain recaptures relaxation and improves bodily functions. Now we have chronic pain. This is pain that may continue for months or years, often associated with conditions such as arthritis, chronic back pain. It may be dull, it's constant shooting, tingling, or burning. It may be treated with both pharmacologic and non-pharmacologic interventions. Long-term effects of chronic pain can cause long-lasting psychosocial effects for the patient. If you don't know what that means, you got to look up what is psychosocial. Non-pharmacologic treatments that may help control chronic pain include guided imagery, application of heat and cold, massage. NSAIDs are used for systemic effect, and sometimes pain is relieved by treating the condition of the involved system and in their immune system disorders. If you don't know what NSAIDs are, please look it up, NSAIDs. Now we have nociceptive pain. This involves injury to the tissues in which receptors called nociceptors are located. This may be found in skin, joints, or organ viscera. There's 4 phases associated with nociceptive pain. There's transduction, transmission, perception, and modulation. So injuries triggering nociceptive pain may be caused by trauma, burns, or surgery. Transduction begins when the tissue damage causes the release of substances that stimulate these nociceptors and start the sensation of pain. Then you see transmission. It involves the movement of the pain sensation all the way to the spinal cord. Perception occurs when pain impulses reach the brain and the pain is then recognized. And then modulation occurs when neurons in the brain send signals back down the spinal cord by release of neurotransmitters. So familiarize yourself with all four of those definitions. Continuing on, treatments are aimed at one or all four phases. NSAIDs work at blocking transduction. Opioids block transmission. Distraction and guided imagery block perception. Drugs that block neurotransmitter uptake work on modulation. So describe and remember what is NSAIDs. How did they block the transduction of pain? I want you to also consider how does distraction and imagery control pain? And then also take a note and think of what are three opioids and describe their actions. Neuropathic pain. This is associated with dysfunction of the nervous systems. So pain receptors in the body, they become more sensitive to stimuli and they send these signals more easily. As nerve endings grow new branches, the signals become stronger. This is often associated with Guillain-Barré syndrome, cancer, and HIV. This is treated with NSAIDs. This is treated with tricyclic antidepressants, anticonvulsants, or corticosteroids. So always look up anything on the slide that you don't understand. Phantom pain. This occurs with loss of a body part from amputation. Patients may feel pain in the amputated part for years after the amputation. It's not controlled by conventional methods, may be treated with TENS unit implanted into the thalamus. So the phantom limb pain, this feels as if it's occurring in the amputated limb. The stump, the residual limb, which is what's left over, the pain is, you're feeling that pain at the discomfort and that discomfort at the site of the injury. Phantom limb sensation, this is the feeling that the missing body part is still there. It may make you feel uncomfortable. It may make them feel like there is a burning sensation, tingling, or itching sensation. So the perceptions of pain, assessment of pain, it's whatever the person says it is. So when we ask patients, are you in pain or how are you feeling? What does your pain feel like? You have to listen to them. Your assessment is actually based on what they say to you. Observable indicators, they may not always be present. So that's why you always want to verbally ask our patients. We can see moaning, crying, irritability, grimacing, frowning, rigid posture in bed. Sometimes this is also described as the following. So read this whole slide. Location of the pain, you always want to know where's the area. You have to identify the affected area. Is it localized? Is it radiating? Is it generalized? And then what is the frequency of the pain? Is it happening all the time? Is it just here and there? Is it occasional? Pain can also be relieved by position changing. So always try to do that and see if that works. Also something like cold or warm compress also helps. You have different pain scales, so pause and write down all of these pain scales and familiarize yourself with these. There's many different scales for different populations, so you will want to know these. This is the pain number scale, so 0 to 10. Now we see Wong-Baker faces. They use this in the hospital a lot. Take a look at this. Non-medicinal methods of pain control. So TENS, then we have PENS. There's binders, application of heat and cold, relaxation, biofeedback, distraction, guided imagery and meditation, music, hypnosis, and massage. So TENS, this uses a small electrical stimulator. It's attached to these electrodes and it blocks pain. Now, PENS, this sends electrical currents through these thin needle probes positioned in soft tissues and the muscles of the back. Biofeedback, this is a specialized relaxation technique. It's used with a machine that measures the degree of the muscle tension, and it uses these electrodes. So familiarize with these different ones. Medicinal methods of pain control. So analgesic medications, you have oral, which is by mouth, topical, which is something you will apply, like lotions or creams that have medication in it. There's injectables, and then there's IV, intravenous. Then there's patient-controlled analgesia. So it's called PCA. There's also epidural analgesia. So nurses are responsible for monitoring patients' pain level. You have to administer the pain medication as ordered. You want to think of what are the physiologic effects of medicinal pain control? How does it affect our body? Try to understand that. And then you also want to know what are some of the adverse reactions to some of these pain relievers? This is one of the PCA pumps, so the patient actually controls it. Pause and try to answer this question. The answer choice that you should have chosen here was 4. It's phantom pain. We went over this a couple times. Pause and try to answer this. The answer here is actually NIPS. It stands for Neonatal Infant Pain Scale. This is what they use on mother-baby units. And then you need to familiarize yourself with the other answer choices. So if you're not familiar, please look them up. Pause and try to answer this. So the COX2 inhibitor for pain, this answer choice is anti-inflammatory. So this is number 3. So the COX2 inhibitors blocks the COX2 enzyme, and it is helping in arthritis pain, so inflammation pain. The only type of medication right now that's available for this is called Celebrex. Pause and take a look. Pause and take a look. Functions of sleep. Adequate rest and sleep are important factors in general health and recovery from illness. Being rested increases pain tolerance and allows improved response to analgesia. So, what commonly happens to people who do not get adequate rest? Think about it. And it's also really cool, kind of thing to think about. When you sleep, you literally build pain tolerance. And it's not just physically, it's actually emotionally too. So, sleep is just such an important part of our life. This is going to capture the different stages of sleep, which you will need to know these. So, stages of sleep, there's rapid eye movement. It's called REM sleep. And this is the time in which you dream. There's a high level of activity. Your heart rate, blood pressure, and respirations are similar to that when awake. As I said, this is when you dream. So, REM sleep. Then you have non-rapid eye movement. This is NREM. This is believed to be the time when the body receives the most deep rest. So your heart rate, blood pressure, and respirations would then be declined. There are 4 stages to NREM. Take a look and try to familiarize yourself with that. A person typically goes through about 2 states of this in their 90 minutes sleep cycle. Okay. So this is the normal sleep requirements. Pause and take a look and be familiarized with it. We'll try to focus on adults for the purpose of this class. So familiarize yourself with, the whole sheet, because you still might be able to see this on a NCLEX question. But for the purposes of right now, let's focus on adults. Factors affecting sleep: working nights or even evenings, changing shifts, jet lag, exposure to too much sunlight, snoring will affect your sleep, caffeine, nicotine, alcohol, exercise, taking naps, stress, illness, fatigue, discomfort, environmental factors. So, if you're a nurse and you're making a care plan, you would want to think about what are the factors affecting my patient. Sleep disorders, insomnia, difficulty in getting to sleep or staying asleep at night. Transient insomnia may be caused by stress or depression. Chronic insomnia can have many causes, and this may require treatment from a healthcare provider specializing in sleep disorders. So insomnia can actually be short-term, and it can also be chronic. Transient insomnia, sometimes this happens from stress or excitement or a change in your sleeping arrangement. So think about when you have an exam, sometimes you have this short-term insomnia because you're thinking about the exam, or you have a vacation, you can't sleep all night. Now we're going to be talking about sleep apnea. This is a condition in which the person will stop breathing for brief periods during sleep. Obstructive apnea, this is the most common and severe. Airways blocked at the back of the throat. You will see snoring. Treatment is CPAP. Central apnea, the diaphragm and chest stops working. Person awakens to resume breathing. Mixed sleep apnea, there's a combination of both. Sleep apnea is characterized by heavy snoring and periods when the person stops breathing. Condition mainly affects overweight, middle-aged men, but it can occur in both females as well as males. Adults with apnea have an increase in sudden heart attack. Infants with apnea are at risk for sudden infant syndrome. And then obstructive apnea may be treated with a continuous positive airway pressure. That was what CPAP stands for. This is a small compressor to maintain an airflow via a mask while the patient is asleep. Snoring, this is a harsh sound. Some of you guys snore. I'm sure a lot of you guys at this point probably snore. It's caused by vibration and or obstruction of the air passages at the back of the mouth and the nose. Excuse me. It may be caused by a poor muscle tone, excessive tissue, or deformities such as a deviated septum. This is a partial blockage of the airway. Sleeping on your side or losing weight may be helpful. Now we're going to talk about narcolepsy. So this is a sudden onset, recurrent, uncontrollable, brief episodes of sleep during normal hours of wakefulness. This may occur at any time and last for a few seconds to 30 minutes. This usually begins around age 25. There is no known cure. Narcolepsy may start as excessive daytime sleepiness. Frequency of narcolepsy is unrelated to the amount of sleep received. Narcoleptics may also experience sudden muscle collapse. This is called cataplexy, and hallucinations and dreams while awake. This condition is usually treated with a stimulant such as ephedrine. Question number 4. So pause and try to answer this by yourself. The answer choice that you should have got here would have been answer number 3. This is narcolepsy. This is characterized by sudden onset, recurrent, and uncontrollable brief episodes of sleeps during hours of wakefulness. These begin at any time of the day. These can last from seconds to more than 30 minutes. We know insomnia is difficulty getting to sleep or staying asleep at night. Sleep apnea is a condition in which an individual will stop breathing for a period of time during their sleep. And then REM sleep was a stage of sleep that included a state of rapid eye movement. So all of the slides that we covered, you should make sure that you are making like flashcards or writing down the definitions so that you are prepared. Now we have question number 5. Pause and take a look at it. I want you to read the question and read the answer choices. Try to answer it yourself. The answer choice you should have gotten here would have been answer number 2. Medications for sleep are for short-term relief only after consulting with a physician. Alcohol should not be used with any medication that induces sleep. Over-the-counter medication for sleep will make you sleepy, and then hypnotics are used for sleep as well. So just make sure for the 3 chapters that we covered, you were writing down your own notes, you're retaining the information, and you're preparing yourself for a quiz that will be graded on accuracy. Good luck, guys.